So now we want to get into some of those issues that I know matter. And I can tell you workforce is one of those areas that is a top priority. It's one of the challenges coming out of the pandemic, but frankly, it was there beforehand. So if I can, please, I would like to introduce Amanda Wagner. Amanda is the Vice President of Workforce Development for the Policy and Innovation Center. And she's well-known and respected champion of workforce development, has a ton of experience. I will just say this, go to the app, look at her bio, you will be amazed. I will just say, when we were looking for a moderator and we had one conversation with Amanda, I was blown away by the depth and breadth of her knowledge in workforce, and I think you will be impressed too as she leads this challenging discussion. So Amanda, if I can bring you up, please.
Good morning, everyone. Good morning. It's hard to come back after a break, but oh my goodness, isn't this the most beautiful hotel and amazing venue? Thank you, Demetrius and team. I am so incredibly honored to be here today, but also just want to thank the team, Silka, for organizing this panel. It's been an incredible, incredible experience preparing for this. And I'll say I've done a lot of panel discussions, I've facilitated a lot of workshops, and I haven't had the level of preparation that Silka has put into this, so just really grateful for the Hospital Association. Today we're going to be talking about forging the future of workforce. I know this is a challenge that keeps many of us up at night, and I wanted to start with that question for you. When we're talking about the future of work, looking at the immediate, the near term, and looking 5-10 years down the road, there's quite a few challenges ahead of us. The workforce is moving at a speed of light that is unprecedented. Things are changing not only daily, but we see the changes coming with AI and automation, on an hourly basis. How are we preparing the future of work to be able to assimilate to this new style? We also have, as Carmela talked about in her introduction, policy that is certainly employer-driven, it's workforce-driven, but it's not always practical for hospital associations to implement this good work. So we'll talk a little bit about how policy also impacts workforce. And finally, as we go through, we have a group of excellent practice-proven practitioners over here who will be providing some insights about how they are really addressing the challenges of workforce head-on. Their perspectives are unique. We have a couple of different lenses to look at workforce through. We have Chief Nursing Officer, Dr. Kimberly Probus. She's with us from El Centro Regional Medical Center. We have Mark Cafferty, who is focused on workforce development from the worldview of economic development. And then we have Connie Lafuente, who has a real great perspective on student voice. So I'm going to introduce everybody and welcome them to the stage. I had a little bit more of an opening, but I think because we have such great practitioners to talk to us today, we're going to have quite a few questions to get through. So let's just go ahead with introductions. First, I have, y'all are backwards for me, but I'm going to make it work. So I've got Dr. Kimberly Probus in the red over here on the far left. She's a quality-focused healthcare executive, a decorated clinician, and a national advocate for patients. Dr. Probus has demonstrated success enabling organizations to receive designation and national recognition for excellence, best ever patient and employee engagement scores, achieving highest quality metrics, including infection, fall rates, and throughout measures. Thanks for being here, Dr. Probus. Next, we have Connie Lafuente, who's the Director of Regional Initiatives at the San Diego Imperial County's Community College Regional Consortium. Connie's the Director of Regional Health Initiatives for all 10 community colleges in our region. She's both bilingual and bicultural. She's a health professional with over 30 years of experience driving strategic initiatives to address healthcare and workforce challenges in our region. What I'll say about Connie is she has such a keen lens on student voice. We were having a conversation yesterday about food insecurity, and it brought her back to her own personal experience and also the experience that she sees on community college campuses every day with students really in need of food. And so for her to really advocate for that yesterday at dinner really amplified why she's on this panel today. She has such a keen understanding of student voice. And last but not least, again, Mark Cafferty, the president and CEO of San Diego Regional Economic Development Corporation, Just an incredible worldview of workforce, not only in healthcare, but across the region, and we'll be bringing his lens of how we can impact workforce. So again, being with the Policy and Innovation Center, I want to talk to you all about what keeps you up at night. And we talk about sector partnerships and addressing some of the biggest challenges in workforce. We have to do it together. And so as we move forward with this conversation, the first thing we have to do is make sure that we're all together in the room, prioritizing the challenges that exist. There are many, and we have to decide which ones are we going to tackle together. So through this conversation today, I hope you'll take some notes, and we'll have some conversations about what those challenges are and how we might tackle them together. So I'm going to go ahead and take a seat over here, but I'd like to start off, if Dr. Provost, you can start with just kind of a 5-minute overview to level set and talk about some of your key priorities and what you've been up to in Imperial.
Well, I'm not a native of California, but I got here as soon as I could. I have been a healthcare practitioner for 30 years, and I've been in leadership for 15. I am the Chief Nursing Officer at El Centro Regional Medical Center, the largest hospital in the Imperial Valley. I've worked in 56 hospitals in 23 states, 24 now. And I've taken with me the best of everything they have to offer so that I can develop plans and strategies for moving forward. I'm a national advocate for nursing for the last 20 years or so. I teach at the University of Alabama, and I'm very deeply connected to the community in which I live so that I can operationalize some of those strategies to help our workforce.
Thank you. And Connie, would you do the same thing, just a quick overview to introduce yourself?
Yes. Hi, everyone. Connie Lafuente, the Director for Regional Health Initiatives for the California Community Colleges here in San Diego and Imperial Region. First of all, I'm so grateful to have the opportunity to be here with all of you and to have these kind of conversations. And sometimes I know we have to have difficult conversations to bring up solutions. So I'm very appreciative of this, and thanks to the Hospital Association. I work for the California Community Colleges Regional Consortia, and we provide support to students to make sure they're graduating with the skill sets to be able to join the workforce. We have 10 community colleges out of the 116 across the California. We have reputable and excellent programs, one being Imperial Valley College, coming from El Centro. They are Aspen Award recipients, which is an award provided to our community colleges nationwide for the excellent student outcomes. Also, they're #1 in their LVM program. They're ranked #1. We have San Diego City College. They're ranked #2 across the state for their nursing program, and #3 across the state. The type of students we serve students that come from all walks of life. We have students that are first-generation college students. We have students that come from military personnel, veterans, middle-aged students that are coming back to get their second career, and students from different vulnerable populations, as well as immigrants and new arrivals. And I'm very passionate about serving in this role because I have been a product of a community college when I started, and I would like to see a raise of hands of how many of us have taken a course at a community college or have been a product of a community college. And so it's really dear and near to my heart, especially when I go to campus every day and I see the students, how hard they're working to be able to get and attain the degrees and be able to join the workforce.
Thank you. Mark, a brief introduction, maybe just a little bit of a landscape of the state of the workforce in kind of San Diego right now. If you can give a little brief overview on that as well.
Sure. First of all, it's an honor to be here as well. This is my favorite industry to talk to, work with, and talk about, and I would say that even if I was in the room with other industries in San Diego. A lot of it comes from my history. I am not from California originally either. I got here as fast as I could 25 years ago, and feel lucky to be part of this community here in San Diego County every day. What brought me to San Diego 25 years ago was my physician wife. My wife had just finished med school in Boston. That's where I was from. Born and raised there, worked for the city, felt I would probably work there for the rest of my life. And she was from Southern California originally, hoping to match for her residency in San Diego. She did that. I think she knew we would never look back. I didn't realize it at the time. we lived up here in Carlsbad, not very far from here, when she was stationed at Camp Pendleton. And it was during the initial Iraq invasion, when she was a field medical officer with the Marine 1st Expeditionary Force, that I feel like I really fell in love with San Diego. So my mind was in a very different place every day. I was just trying to kind of keep focused on my work. And so as I drove in and out of work, spending as much time as I could learning about this community. Never really been part of a military community before, so that really hit me in a very different way at that point in time. And when she came back from Iraq, I remember the years that followed, all the work that I felt I needed to do with the connections I had in the region in helping her corpsmen and women as they came back try to transition into careers here in San Diego, and seeing just how difficult it was for them. Despite great programs at our community colleges and elsewhere, just the challenges for somebody to navigate that. Having practiced and supported medicine in the most difficult of circumstances, to come back to California, not be able to really find a position here, and then go back to their home of record and start working in a non-medical role somewhere. And so I know a lot of you have worked on strategies that help with that since. I know that we're in a better place now than we were back then. But I just share that as an example of what I'll probably spend most of my time talking about up here, and I may start to sound like a broken record. I run our region's economic development corporation for the county, but the real currency in our economy is our workers, is our talent. You'll hear people refer to it in lots of different ways, and I mean across every industry. This industry, I think, has the unique opportunity to train people in ways that other industries cannot, and I'll spend as much time as I can today talking about that.
Thanks so much, Mark. I want to get started with Dr. Probus and talking about those 56 hospitals that you've worked at. I was actually talking in the back this morning, and I mentioned your credentials, and in the back said 56. How is that even possible? I can't quite do the math. So with all that experience, you mentioned that you have a 9-step process for recruitment, and right now recruitment is essential for our workforce. So I would love to just kind of high level go through that 9-step process, how you found success, and maybe brag a little bit about your status right now at El Centro with 0 nursing vacancies. So let's talk about this process.
So those 9 steps could easily be 12, but that's what everybody wants to hear about. So this will be the longest answer that I have, so bear with me, because this is what the information folks want to know. First of all, you become, you get to have 56 hospitals in your portfolio when you're a consultant, right? So I cheated. But the job that I currently have is my full-time permanent forever job. And it took me a whole work life to find it. But I have no nursing vacancies, and it's only the second time in my 30-year career that I am able to say that. And if you think about how many vacancies are in your hospitals, I'm willing to bet the number's not 0. So how do we do that? I work in 10-year plan increments. I got about 10 years left maybe, right? So it's always 10 years, even if I know that my assignment there is only 8 weeks. So I leave behind a work plan that they can use for at least 10 years. So I start with a community survey. And that's where I look at, the percentage of owner-occupied housing. Is the population increasing? And we'll talk later about how the nursing workforce, and not just nursing, it applies to anything. We could be talking about welders right now in the same 9 steps work. But I look at the community health assessment if one has been completed. I was fortunate to come just at the right time. The director of our Imperial County Health Department is here today, and I came at the right time to be able to participate in our community health needs assessment. So I know a lot about our community, and knowing your population is critically important. Then I look at the local statistics from the Bureau of Labor Statistics, the Economic Workforce Development groups. And then I look at site data. What are our employee engagement scores look like? What is our attrition rate? And I put all of that big assessment together and develop a 10-year plan. And on day 1, I start laying the groundwork for the next 10 years. The steps that we use in those 9 strategies that I kind of take with me are built on the need. So in year 1, day 1, I do my assessment, right? And then some of the first year strategies include responding immediately to critical needs. So at 3 large 500 beds or more academic medical centers during the 3 spikes, each wave of the COVID crisis, I was able to recruit hundreds of nurses at a time for 3 of those large places in very different parts of the country: Alabama, Kentucky, Virginia. So I responded immediately to critical needs. The most impact that I made, or the largest number, was through volume recruitment. I partnered with an agency to do volume recruitment based on geofencing. They have all kinds of, I don't understand all of that, that's not my field, but they have ways to reach people who are local who can respond immediately. And then there are reimbursement strategies that were helpful in recruiting those people and paying them bonuses for responding urgently. The second is contingency labor, your standard travelers. I don't have any travelers at my hospital, but I'm sure many of you still do have a lot of travelers or agency workers. That's the second one. And then the third one is the referral programs. And as part of my assessment and as one of the strategies, I would call everybody who'd left in the last 12 months. First, to ask them why they left, because I need to understand what kind of culture is driving people away. Why did you leave? And the second question is, do you want to come back? And the third question is, will you bring a friend? So if you come back, I'll give you the sign-on bonus that they were offering, and I want to make it clear that this is usually not about money. It's about authentic, engaged leadership that retains people. But if there is an opportunity for a sign-on bonus, even though you've worked here before, we'll give it to you. And if you bring a friend with you, we'll give it to them, and then we'll give you half of it again. And that worked for me in one place really well for getting people to come back. So that's 3 immediate. When it's an emergency, I got to do something right now to take care of the patients in my charge. And those are the 3 strategies that we use on the first day if we have to. And then start planning during that first year to lay the foundation for the next 10 years. In so doing, we train the trainers. What does the education department look like? Are there preceptors really precepting people the way that would make you proud? There is a well-known phenomena among nursing. People say, I don't know why this happens. I know why it happens, but that's a different topic. There is a culture of incivility among nurses, right? They're great to the patients and they're great to the leadership, but they're not great to each other. And so I have had to have one strategy of, holding a town hall meeting to say, we only have one HR rule. If you're the reason someone leaves, you're going with them, right? And then mean it. So laying the foundation, training the trainers, making sure the preceptors are engaging, and that the likelihood of retaining the person that they're precepting is based on genuine, supportive leadership. I dive into the schools, secondary and post-secondary, right away. There's not a school in my county, a high school or college that I haven't visited. I've joined the advisory councils for the nursing programs for a couple of them. I want to know what's going on. How many seats do you have? How many do you fill? I've even recruited 2 students to our local community college. My colleague here was remiss in not saying that Imperial Valley College is the #1 community college in this country, the whole country. So that's pretty amazing, and you've done some fabulous work, and I'm so honored to be part of it. Very, very honored to be part of that. So I dive into the schools, whatever I can do there. I teach locally. I'm still teaching for the University of Alabama because they had a need when I was working there. I went to school there. I got my first doctorate from there. And I'm very, very engaged with students from high school on. And that's, just a personal point of satisfaction for me, but it's also a really good recruitment tool on that 10-year calendar. I'm the only person you'll ever meet who has a GED and 2 doctorate degrees. Amazing. So I give full credit to folks who support students because they're, I could have easily fallen through the cracks And then foundationally, develop relationships with the community leaders like the ones that I've mentioned here. And then in year 5, that's when you can start using some more of the strategies. International nurses, that's reserved for year 5 because it takes 5 years to get them here, I think. It's extremely expensive, but they are long-term employees. I have started labor pools with affiliates, even competitors. You got to get out of the box, all right? I don't even have a box, so that's good. But you can develop labor pools with affiliated and non-affiliated entities where you can share staff. Because, you know, let's don't pretend we're not swapping the same 100 nurses back and forth every year anyway, right? So developing labor pools and then creating a residency. My education department is very robust for the size of my facility. And the talent in our education department is hands down the best I've worked with. And because of that, we have an evidence-based residency program that prepares nurses for whatever path they want to pursue. There is another phenomenon among nursing that we're the old guard. You know, the senior, the tenured folks tend to guard our practice and guard our territory, and we just don't do that where I work now. So in the residency, we will prepare someone for an entry level into a specialty. You know, that's kind of against the nursing rules. You don't go straight to ICU right out of school. Well, why not? I did it. If you have the talent and you're not afraid to practice the skill, we'll teach you how to use it. So it's an open and inviting residency program. We have an internship program where people who are maybe not in the residency can still have an extended orientation so that we're sure that they're completely effective nurses on the day that they are released to practice independently. We have increased hours for clinicals so that more students can be rotated through, and that allowed our local community college to increase the number of seats, apply for an increase, and I think they got an increase in the number of seats in their RN program. And then we allow apprentices to use the skills that they've learned in school. That's another outside of the box thing because I'm supposed to guard that, but I refuse to guard that. If you've been checked off on it by your instructor, who I personally know in nursing school, you can do it in my hospital, and there's no rule against it, as long as it is supervised by a practicing licensed nurse in this state. So we give them a better experience, they're able to use their skills, and then when they're practicing independently, they're not afraid to do it, and they do it right every time. And then on year 5, I'm still planning for the 10-year mark, where we support advanced education, which are retention tools. We have a tuition reimbursement program that helps to turn novices into experts. That's a nursing theory. And that increases job satisfaction, and it helps us to maintain our skill mix. And then in year 10, the goal is to, we're up to 9, this is number 9. In year 10, the goal is to mentor in an ongoing fashion. So we have study groups in one hospital. I couldn't find CNAs. I couldn't get a CNA anywhere. No nursing assistants to be found, but there were 400 nursing students within 20 miles. So I just thought, how can I innovate something here? This was in Hampton Roads, Virginia. And I said, okay, I'll tell you what, I'm going to all the nursing schools and I'm gonna pitch to the students. I said, do you spend a lot of time studying? Yeah. Do you work? No. Why don't you work? Because I gotta study. This nursing content is pretty hard academic content. So I said, okay, if I could give you, if I make a library, it's really an office or maybe a closet, but if I could make a library and put one of my people in there who is a master's or better prepared director of nursing in some department for 4 hours a day, could you work for 4 hours and then study for 4 hours with a mentor? Yeah, we'll do that. So I recruited 19 students to be my nursing assistants. So that eliminated that vacancy, and in return, they would work for 4 hours. I would pay them for those 4 hours, and then for the next 4 hours, they could study. 100% of those students passed their NCLEX on the first try, and 18 of the 19 became registered nurses in that facility. So it's about pouring in and being creative. And ongoing mentoring applies to study groups. I have a Facebook group where at night what I do for fun is mentor 76,000 nursing students. And it's probably the most fun I have all day is at night talking about, content with nursing students. And then an opportunity to mentor others by sharing some of these strategies. And I appreciate the honor of being able to do that today.
Thank you, Dr. Provost. That's a lot. Yeah. We'll lean into some of those solutions a little bit later. We have a couple more questions around some of those solutions. But again, I know last night when we were talking at dinner, there was quite a few folks that were ready for those nine areas of opportunity so that we can help impact the region here. Connie, I want to go to you next, and I want to talk about the regional consortium that you support. So that's 6 nursing programs, 85 allied health and behavioral health programs. I really want to lean in a little bit and talk about the state of those programs, what we may need to help advance those programs to see their true potential, and just kind of what needs to keep working here in the region for those programs.
Right, thank you. Dr. Purvis, that was amazing. So thank you so much. Yes, a lot to learn from you. Yes, we do have 6 registered nursing programs, 85 plus allied health and behavioral health programs, and I provide support to all of them in matters regarding legislative issues, increasing collaboration with health facilities and academic partners, as well as increasing opportunities for our students to access clinical placement sites and recruiting faculty, qualified faculty to teach our students. In addition to that, I support new program development. So I'm really excited to share that in 2026, we will have the PsyTech program, which I've been working on since 2019, just to give you an idea on how long it takes to actually start a new program because of all the different requirements that need to take place. So in order to support our nursing and allied health students, what we really need is clinical placement sites. I know that we work with the health facilities and you welcome our students, and we're very grateful for that. But we really need to increase the pace of clinical placements. So pre-COVID, just to give you a little bit of background, pre-COVID, we were doing okay with clinical placements, even though we had some hiccups here and there. But after that, things have really aggravated. So for instance, the number of students that are welcome for rotations have decreased. So that has put a big burden in our community colleges, especially on faculty. Also, some of the rotations have been declined. So then we have this group of students that we don't know where to place them. Some of the declinations come to us 2 weeks ahead when the student's supposed to start their placements. So it causes a lot of stress, not only to the students, to the program, and also to the curriculum that we need to deliver. Just another little bit of background, the Board of Registered Nursing, and I'm just going to talk about nursing, but this applies to also allied health, but they have different requirements. But the Board of Registered Nursing mandates that students need to have 500 clinical placement hours to be able for them to graduate. And a minimum 30 need to be in specified categories, such as mental psych tech, OBGYN, PEDS, and et cetera. So when we are not able to provide these clinical sites and hours to our students, what happens is our students are not able to complete the program. But it's also a catch-22 for the health facilities, because when our students are provided limited amount of hours, so they are coming prepared theoretically, they're very strong. However, when they're not exposed to practice, they don't have those critical skills, such as, for instance, how to talk to a patient in stressful situations, how to handle stressful situations. Mm-hmm. So what you're getting and your workforce, your first year nursing students, are students that are well prepared, but they don't have that life experience. And what happens is that if they don't have that life experience, most likely they will quit within the first year, and that becomes a problem for your health facilities because now you're dealing with retention issues. Or you need to do additional training, so that's cost, funds, and resources. So I think it's very critical to come to a solution on how can we increase these clinical placements for our students and provide those live experiences. One of the biggest threats for us recently in the past 2 years is also that there's other programs coming from out of the region, out of the state, including private colleges. There is one right now, a private college coming in that is promising to graduate 400 students in the next 3 years. So what is that doing to our community colleges is they're strangling us down. I'm going to give you just one example. One of our colleges currently, well, in the past few years, they've been able to bring in or accept 56 students out of 300 applications they receive. So at any given time in any semester, we receive between 300 to 400 applications of qualified students. That means they meet all the requirements. But this particular college was able to bring in only 56 students per semester because that's all the number of clinical placements they could actually have. But in 2024, they were forced to actually bring down even less students, 42 students, because they did not have those clinical sites. So, you know, that causes a lot of hardship, especially to the type of population that we're serving. And we heard about Carmela earlier today, that we want to increase the diversity in the health sector. We want to increase the diversity with faculty. So what is that doing is actually that's diminishing those opportunities. So that's one. And the other is, you know, to have these conversations, and I know some of these conversations are difficult to have, but to have these conversations with the decision makers, because I'm not sure if we have the right people when we're meeting with the health facilities at the table, and they are in the known of what is really happening with those clinical sites. And the other thing, humbly I would ask, is that some facilities, the preceptors, they really don't want to welcome students. And the students feel bad. Some of our students have to drive 2.5 hours to a clinical site. And some of the preceptors don't want to work with them because they say they don't have time. And maybe if you can incentivize your preceptors, you know, that this is something, it's an investment in the future, it's an investment for your health facilities, that would be great.
I appreciate that, Connie, and definitely something that I've heard throughout the day and just around is clinical sites are really a real great need in our region. Mark, one thing that you've said to me that really resonated when we've talked in the past is that although we have these challenges with clinical placements, healthcare is really an unprecedented place for training and development. The folks that are leading the way are really open to training the folks behind them and vice versa. And so I would just love to know, for you and your experience with EDC, you really do lean into developing the talent pipeline. So I'd love to know what you all are working on to make sure that we have this supportive network happening in our region.
Yeah, absolutely. So, you know, for starters, just to kind of level set a little bit, and you all may know this already, some rooms of folks wouldn't know this. So, you know, we're in a county of 3.4 million people. It's about 1.2 million jobs in this county. 1 in 10 of those jobs is a healthcare job. At least 1 in 10 of those jobs is a healthcare job. So out of the gate, speaking as someone who runs the Economic Development Corporation, that's a big enough industry to matter anywhere. That's a big enough industry to matter just by way of those numbers. The other thing that's so important about healthcare is you impact the economy in other ways that other industries do not. So not only do you employ those people, but the quality of healthcare in this region, when we're talking to a business about coming to San Diego, growing or staying, the quality of healthcare, the access to quality of healthcare is an economic development advantage and selling point. So the better the quality of care is in the region, the stronger the business community becomes, the stronger the talent becomes. People make decisions on where they want to be for a whole host of reasons. But one of those reasons is for their children, for their families, is the quality of healthcare through their job in the region that they're in, a high quality of healthcare compared to other places that they could be. So the stronger our healthcare system is, the stronger our economy is. And at the end of the day, you care for our families. You know, you care for our neighbors. You care for our parents and our children. There's no more powerful industry than that. You know, biotech gets a lot of attention in San Diego, and it should. It's an amazing industry. But at the end of the day, when I walk into Rady Children's Hospital with my sons, at any point in time, that's the most important place in the world for me, right? Depending on what's going on in our lives. So I say all that to say this is such an important element of any economy, and I think even more important in San Diego. What Amanda and I talk about a lot is, and again, you all probably know this, but I'll just state it as an outsider. You're the best example of a teaching and learning industry there is. And if I go back 35 years to when I started doing this work in Boston, and I was working with 2 different industries, we saw stark differences. Boston has a huge finance industry, and that finance industry needed to figure out where its future workers were coming from for a few reasons, and because of some mandates. The healthcare industry was very different. The healthcare industry was facing actual shortages, needed to grow and couldn't potentially grow, was looking at a diversifying city of Boston and knowing and understanding that they couldn't even speak all the languages of the populations that were walking in the door every day. The cultural competence needed in healthcare was so significantly higher than it was then and still is now in something like finance. And so when I'm working with young people in healthcare back in Boston, again, 35 years ago, and we walk into a hospital for the first time, and they meet adults doing some jobs that look understandable to them, like doctors and nurses, and also learning that there are, dozens, if not hundreds, of other careers in hospitals that they don't know about. But when someone says to a young Vietnamese student or a Haitian student, "Can you come over and talk to this patient for me because I can't?" and that person is a nurse or a doctor asking you to do that, the light bulb that goes off for a young person who maybe has been brought through a system thinking that their being a English language learner was a disadvantage, suddenly realizes how advantageous that is in a setting where people care about that and need to care about that. So there are light bulbs that go off in the teaching and healthcare that don't go off in other places. The other thing that I think is so important is when we were setting up the structure of those first programs that we were doing in Boston, every industry looked to healthcare. And they looked to the model, and I'm not sure the model still works the same way, but back in those days, when a doctor was figuring out what she or he wanted to do, they went through a series of rotations. They tried to see everything before they decided what they could specialize in, what they wanted to specialize in, what made sense for them. We don't train people that way in other industries. People don't do that in other places. And in healthcare, when we started bringing the young people into the hospitals, that's how the hospitals wanted them to learn. Not necessarily going through the same rotations you would as a medical school student, but going through and learning all about the hospital, all about the broader healthcare community around you, all about the careers in healthcare. I've seen healthcare organizations, and we did a site visit to Indiana years back. I've seen healthcare organizations say, as a CEO of this organization, I sat down and I realized no one was taking advantage of our tuition reimbursement. And I couldn't figure out why. And when I sat down and had lunch with employees, they said, "I can't front the money. You're going to reimburse me when I'm done. I can't front the money. I don't have enough right now." So that organization just decided to front the money for all of them. And our room full of people from San Diego said, "Well, how did you get the money back?" And they said, we didn't. And how do you know that did you make them sign something that they had to stay with you as an employee with your organization? And he said, if they go out and they take on a position as a nurse or a clinician somewhere else, that's a win for us in the healthcare community, so we don't consider that a loss. That doesn't happen in other industries. So I share all that to say that when we think of, the real solutions and the real challenges and opportunities in this workforce are what my 2 peers up here have been speaking about and what they do day in and day out. What we need to do, I think, in my opinion, is continue to get young people to know and understand the opportunities that are available to them. The opportunities of an industry they can't just land in, but that they can move through in ways that they can't move through other industries. That there are more academic programs that they can go into than they realize. Some of them start shutting down at a young age thinking they can't be a doctor or a nurse, and they don't give themselves the chances later to be strong enough to think that they could find themselves in that setting again. We need to make sure that we're not sending those messages. I was really hopeful coming out of COVID, and I'll thank every single one of you who worked in the healthcare industry and still does through that period of time in all of our lives. I was hopeful coming out of COVID that young people would emerge wanting to be the folks who are on the front line, wanting to be the individuals who we all should have been celebrating, and in time. And I'm not trying to show my politics here. I'm just saying I went from watching people walk out every night and bang on drums outside to celebrate healthcare workers to seeing videos of people screaming at healthcare workers. And this is just the barrage of things that young people see in a world where they're barraged with everything. We have got to figure out, as an economic development community, workforce development community, academic community, how to help you break through that to get young people to realize the possibilities and the opportunities that are there for them to not only be workers and successful in healthcare, but to give back to their communities in ways that they won't feel in other industries.
It's really helpful, and I think when we're talking about talent development and making sure that we have the opportunities and access to experience those things, even in the K through 16 collaborative that you all work in, to make sure that we have adequate opportunities for people to really be exposed to these things is really a big differentiator in San Diego, because we're teaching people really young.
May I add something
Sure,
to
sure.
that? So thank you so much for bringing that up, Mark. So I just wanted to kind of give you a perspective also, the type of students that we're getting, right? They're very different than we used to have. So the students that we're getting, the new employees you're receiving as the part of your workforce, they're purpose-driven. They don't care about benefits. They want flexibility. They want to enjoy life. They want to travel. So it's a very different type of population. So understanding that as well is very important in terms of providing and sharing the purpose of this profession or this occupation. And I have an opportunity to also be an adjunct, and I teach a course in Introduction to Health Careers. And it really breaks my heart when I see very bright students that go, I want to be a doctor, I want to be a psychiatrist, a psychologist. But when they see that level of education they need, and these are probably first-time college inbound individuals, they go, oh, my parents don't have that kind of money to put me through school. Oh, I cannot be a doctor because I thought, you know, there's no way I can pay for this. And these are extremely bright students. So to be able to just share with them, there's career paths. You can start as a CNA, move up LVN, RN, and go into the medical school. Or you can become a peer support specialist and move into the mental health, behavioral health path. So those are very important conversations to have, to be able to say, yes, you can do it, yes, there's pathways, and yes, you can make it happen. So.
I love that, Connie, and really goes into a segue for my next question with Dr. Probus, thinking about the talent pipeline and doing a little fact checking for you, saying that you have 0 vacancies right now at El Centro, and going to look on the website, but you still have jobs posted, and that's really because you still want to make sure that you have room for those people that you're developing at IVC. So just talk about that strategy and why you make sure that you're still engaging with the community college even though you have no vacancies.
Well, before IVC, I try to recruit them as volunteers when they're still in high school. Our volunteens participate in the career and technical education program tracks from the Imperial County Office of Education, which is part of the Imperial Valley Regional Occupations Program. And those two are linked, and it reaches into the high schools to expose students to potential careers. One of the things I did at El Centro Regional Medical Center was to expand it from just nursing. We would do a tour and let them tour the hospital, and we had a few opportunities to let them job shadow nurses. But there's other tracks too, and a hospital is a micro community, right? So we have security. Well, they have a cadet track that fits well with that. We have an emergency department. They have a track that graduates first responders from high school, or they can be a CNA by the time they graduate from high school. So reaching even further back, I don't know if there's a kid in Imperial Valley who doesn't know me by now, but if they're in the career and technical education tracks, they do know me, and I'm on their advisory council. That's strategy number 11. So there are lots of things that we can do. We expanded the program. We allowed job shadowing instead of just a tour. I attend their career phase, career fairs. I still teach locally. I have a good example from Alabama. I graduated there, but I was teaching there. The hospital directly across the street in Tuscaloosa from the Capstone College of Nursing at the University of Alabama is called DCH. It used to stand for Druid City Hospital, and it's 100 years old or more. And it started becoming known among the nursing students as DCH stands for Don't Come Here. So I'm like, we have to fix that. I think they have 4 nursing vacancies right now, big place. But it's about getting locally involved, knowing the population, and meeting their needs. It's a whole negotiation strategy. But I'm fortunate where I work now that I'm able to start early, be their champion, engage them as students, volunteers, then interns. I'm working with the Dean of Health Occupations Programs at our local community college to start an apprenticeship program, which is another level, and then they can job shadow professionals. Mentor them through school. I've supported young people with letters of recommendation to their chosen programs, made calls on their behalf, offered advice, provided education, increased their use of practical skills like we described earlier. By the time, if they get in early at one of those first phases, they're already an employee when they graduate because they were a volunteer or an apprentice or an intern, or they went, so then they can go through residency. And when they graduate from that, they start at a higher rate than their peers who aren't already employees, because now they're tenured. They have a couple of years with the facility in a different job. So that provides a lot of job satisfaction for them. And then we allow them to use or encourage them to use our tuition reimbursement program to continue to learn more and climb our clinical ladder at the hospital. Great leadership retains them, and I have to say that this is very time consuming. I spend about 20% of my time on recruitment and retention and the relationship development with all of these different entities and the students themselves. And I can do that because I have a fully engaged boss who is also a nurse who completely gets it, and he lets me. So shout out to my boss. So it's you have to be able to, you can have the skill and you can have the talent, but if you're restricted from using it at my level or at the volunteer level, then you won't get the outcome you were anticipating.
Thanks, Dr. Provost. I think when we move forward and we're talking about the needs of workforce and how to attract talent, one of the things that's fundamentally different about healthcare is that you all are the front lines. You have to be in the hospital system. You have to be there taking care of patients. You don't have the flexibility of working, remotely or a flexible schedule. So, Mark, I know you've been, thinking about this at EDC and looking at different ways that you can attract talent to healthcare despite having to have a pretty structured schedule. Is there any way to think outside the box here? Is there any way that maybe the healthcare providers on your board are looking at how to structure time differently to attract and retain the workforce?
Yeah, I mean, I don't know what the strategies are that would work best in each of your businesses. I do know that the dialogue that we're having across the economy these days since the pandemic is a very, very different dialogue than we were having, that anyone was having pre-pandemic. We have businesses, a lot of you may know who Cubic Corporation is. Cubic is a homegrown defense tech company here in San Diego, also a leader in transportation technology. If I brought you all out to Cubic today, there might be nobody in the building. And there's thousands of people who work in Cubic, but they're just not back. This far past, sort of the peak of the pandemic. In every discussion that we have, we used to have an HR roundtable that focused almost exclusively on talent recruitment, discussions. And then that turned during the pandemic into almost like an employment law help group, just kind of trying to figure out sort of what are you doing to shut things down? What are you doing to open things up? What do we need to know? And now they just continue to meet, and almost the discussion is a hybrid of that. Some people are talking about their workforce that's still not back. Other people are talking about their workforce that never left. Healthcare is an interesting one, and I think that is going to be a challenge. I think to some of the things that were said about who's attracted to healthcare, the recommendation I would make from what we've seen is, in a day when more and more people are posting jobs and letting folks know you don't even have to live here to have this job. We're fully remote. We're flexible schedule. Those are being seen, whether you all, we agree with it or not. That's being seen by talent as a benefit. And people are looking at job descriptions and they're making decisions on that. And I have executives on my board who say, I mandate that everybody is back. Good for you if you can do that. But the reality is if you're struggling to find talent, you have to stay very flexible. Some people got so flexible during the pandemic, it's actually hard for them to roll it back. Healthcare, not all hospitals are alike, not all clinics are alike, not all practices are alike, and I know people have to sort of think about their workforce and think about what it takes to, at the end of the day, serve and support the patients walking through the door and make good on your mission while also trying to be as supportive of the workforce as you can. I think that's why you have to think about things like better tuition reimbursement than other industries, better career mobility opportunities than other industries, other things that you can wrap around a worker to make her or him feel valued that may not say to them, and you get to have Mondays and Fridays off. There may be some ways to do that, and the warning that I would just share across any industry that we've seen is the worst scenario in businesses these days is that some segment of the workforce can be remote, but another segment cannot. In any facet of our life, if Amanda's told that she and I have the same role, but that I can do it more flexibly than she can, then that's not fair, truly, to her. So I think the challenge that I would just say is, as you're thinking about and trying to implement those initiatives, know that there's a lot of people across a lot of industries thinking about it. Jane Finley, who was in here earlier, is a member of our executive committee. June Komar from Scripps Health is as well. All of the major hospitals serve on our board and lean into this discussion with other sectors of the economy. But I think these days we all have to think about doing everything we can to make a holistic experience for a worker, something that makes them feel valued, want to stay, want to continue to grow with an organization, and there's some different ways to do that.
I appreciate that. It is really a complex issue, but I think, and Dr. Provost, I'm just curious if you have any follow-up to that with your experience. Have you had any hospital systems that have been able to make more of a flexible schedule or more attractive to employees, or it really is this just kind of the state of our workforce?
Like you mentioned earlier, it is, there are people in the hospital who have to be cared for by people in the hospital.
Right.
But there are so many of our jobs that can be adapted. We adapted seeing your doctor, right? It was telehealth. We adapted even that. So there are going to be ways that are innovated. I think truly understanding what people's needs are. Some people want to go to work. Some people never want to set foot in the building. So I think if we can find ways to adapt those jobs that are traditionally in-person jobs, we can do that.
Yeah,
There's an entire zero census hospital, is what they call it, in Missouri, that is staffed by critical care registered nurses, residents, like everybody that you'd see in the hospital you can find there, but their workstations, they're not up walking around. They have these really wild looking, it looks like the panel from the control room on the Star Trek Enterprise. And there's a nurse sitting at each one of them. And there's all these screens with patients on them. And they're providing nursing skills. They're supporting the nurses who are in person. Maybe you don't have a critical care nurse in your hospital, but there's one on a monitor watching the patient with you and giving you advice and telling you what to do and running codes. So we've come a long way. I think the best way to, as Mark alluded, is to understand the workforce and what their needs are. And the true diversity in our workforce now is generational rather than along ethnic lines. And I've tried my very, very best to understand there's five groups in the workforce. I'm Gen X and not everybody is, right? So I live to work and they work to live. They just want to work the number of minutes it takes to pay the light bill. So I need to understand that. I need to be okay with that and say, okay, well, you can work a 4-hour shift today because you're going hiking. And I have to embrace it and I have to be good with it, right? So, and sometimes, occasionally in a small hospital, I'm the nurse who replaces them. And that's why I keep my skills.
Thanks for that. Connie, I want to talk and transition a little bit back to clinicals, and I know we talked about it a little bit already, but it deserves mentioning again. I want to talk about the Allied Health Consortium, Healthcare and Allied Health Consortium that you're a part of, with over 200 members that are really trying to figure out clinical placements and how we can make sense of quality clinical placements for our students. So I just want to talk a little bit more about the strategies that you're enacting and what we're thinking about to improve the opportunities for clinical placements in the community.
Great, thank you so much. So in the San Diego region, in San Diego Imperial region, we have a consortium. It's the San Diego Nursing and Allied Health Service Education Consortium that was established in 1996 by 2 retired nurses, and they did a fantastic job until a year ago when they decided to travel the world. And so we had to transition the leadership team. So we transitioned the leadership team, and I'm very excited to say that we have 11 different type of representatives in the team that include the health facilities. We have UCSD and Tri-City as the chair and co-chair. We have 4-year institutions, private and public, and we have community colleges, private and public. So what it does is it brings us all together. So it's kind of like playing nice in the sandbox. And we all come together to be able to kind of find out what are the requirements for the health facilities. What is it that they need to onboard students? What are the, different flu forms, background checks, et cetera. And for that, we use an ADB Complete, which is a software communication platform. So where we go ahead and input every information there. So it makes it really easy for the hospitals to say, okay, these students meet all the requirements, so we're gonna bring them in. So we heavily work on clinical placements as well in that space. And the reason why is because every single health facility has different onboarding requirements. So some have 5 different modules students need to take, be able to be onboarded, and other facilities might have twice as much. And I just wanted for you to please keep in mind that these onboarding modules and everything else that students have to do, they're doing it outside the education setting as well as the clinical placement setting. So it adds a ton of time, especially if students have to go to 2 different health facilities. So we're trying to come together in the room and streamline those processes and see if there's anything we can do as simple as just creating the flu form declination, that it can be the same across the board. So a student doesn't have to fill out 3 of those. Those are some of the strategies we're working. We do have, so some of the priorities that we're working on is that consortium had 800 members, but there was no such thing as 800 members. So we were able to bring down to 200 members. These are active members. And again, we have this leadership team that meets regularly, and we're making big strides on clinical placements, as well as we're trying to have some standardized calendar of by when schools need to request placements and by when health facilities need to respond. And I would ask for the health facilities to please honor those deadlines, because we have several of the health facilities that do not honor those deadlines, and we are in pins and needles trying to figure out if our students will come into the facility or not. So that's one of the big issues that we're working on as well.
It's definitely a great call to action. And one thing when we're talking about clinical placements, we had a conversation, and you just mentioned, Dr. Provost, about going hiking rather than working your 8-hour shift, but just the interests of our workforce have changed. And one thing we talked about in planning this conversation was if we wanted to bring out the topic around burnout and if that was something that we wanted to address. And really, I was challenged by that to talk less about burnout and more about resiliency and workplace maturity. And so I do want to open up a question to the group about just how we continue to make sure that we are developing and reinforcing the skills that are really valued and maybe are essential skills, but aren't theoretical skills of workplace maturity and resilience. How are you making sure that those things are reinforced in your healthcare system?
Well, we start during the clinical rotation, explaining what life is like as a professional with a big, I'll say girl, but a big girl job. Taking care of other people is a highly responsible job. And we have to convey and demonstrate what that looks like. We've done a lot of outside the box thinking. I have, for resiliency, I have been very creative in my scheduling. For instance, I have 3 nurses who can each work on the same day for 4 hours, so that's a 12-hour shift. right? You know, one of them has some food restrictions where she has to be home at a certain time. One of them has a health issue that requires them to work a short shift. And another one has a prior obligation babysitting grandchildren that requires her to be home after school. So they work 7 to 11, 11 to 3, and 3 to 7, and that's my 12-hour shift. But they all have to work on the same day, and they've agreed to do that, and I let them because I still get that shift filled. Resiliency is important, but it starts with accountability. You know, first this is the expectation, and then we can meet your needs as much as possible. But I'm always honest and kind, but I'm very transparent about what it requires. And I have my very talented educators identifying very early in their tenure what gaps are present and what needs need to be met for each individual staff member. And then again, eliminate that toxic environment. When we partnered with our nursing school, we start early with eliminating the toxicity that sometimes, it's a high pressure environment, and that's unfortunately sometimes a byproduct. And so there's that, but we increased our clinical hours. You know, I talked about how there's unwritten guardianship rules. OG stands for old guard, but there's an OG rule that says you have to do your nursing clinicals Monday through Friday, 7 to 3. Not at my place. You can come on Sunday, you can come at night, and that's how we were able to support our community college to increase their number of nursing seats, was to increase our availability for clinical rotations. And not all of them, only 30 hours or so are required to be in a specific place. So we have 5 sites of care. And I put them all over the organization in all 5 sites. So we just use non-traditional methods for all of that.
That's great. I'm interested, Mark, from you, just workplace maturity in general and kind of looking at the future workforce and talent development. Is EDC really leaning into that space? Is there any opportunities to work on workplace maturity skills, those soft skills, outside the college or higher ed setting?
Yeah, it's hard pressed to have any discussion that we're having about economic development today and not have people in the room talking about these very issues. Mm-hmm. And people think economic development is about land use. It's about bricks and mortar. It's about tax incentives. And at the end of the day, economies thrive or don't based on talented people who can work there, sustain jobs, grow jobs, create new businesses, whatever it might be. I think that employers in general, hospitals included, clinics, but employers in general have a much bigger role than they may realize in trying to make sure that the culture that they're creating is right for everyone, but it's not necessarily the same for everyone. I think when you talk about the differences in generations, I look at my wife's small business. So my wife is a physician. Her business is right next to the Sharp Coronado Hospital. She's a dermatologist. And she has about 16 people who work for her, and then there are 3 physicians. But the 3 physicians function with the schedule of 2 physicians. They sort of break that up so that they all have time with their families because they all have families. Her entire workforce is women, and they all have a lot of family to care about, not just their children, some of them their grandchildren, some of them aging parents, whatever it may be. So they all split shifts in different ways, a lot of what was just described. And I watch her all the time trying to figure out what other things can I do to make sure that they as workers continue to feel valued and connected and happy to be part of the organization. And small things, when she first took over that business, the person who had been the physician there before and the owner did not buy new uniforms for them. So she buys new scrubs and new uniforms for them often. That seems like a small thing, but that was something that wasn't done for them before. As some of them have moved out of clinical roles into customer-facing roles at the front of the business, she's given them a clothing stipend to make sure they can buy the clothes they want to be able to do that. They didn't have any kind of profit sharing. They didn't have any kind of retirement. She's implemented all of that, and while I watch her late in the evenings doing all the administrative work to try to make that work, it's to try, she has not lost a person. She didn't lose a person through COVID. She hasn't lost a person since she started that business. They all stayed there. And I think part of it is she's amazing. I mean, I'll just straight up say she's an amazing person. But I think like all good managers, forget that she's a physician for a moment, she's just really trying to think about what are the things that workforce needs. And that changes. It changes with people's lives. I don't think I need to tell this room full of people that we should always operate with the assumption that everybody who works with us and around us is probably going through more than we realize. And when you can be the kind of setting where people care about that, where people focus on those things, where people feel like they can actually even talk about that stuff, and maybe not be in on Thursday because something's happening in their life that won't allow them to be there, and not think that the job won't be there on Friday. I would just encourage all of you who are in a management role, director role where you're running any kind of business, to try to think that way as often as you can. And I guarantee you the workforces that we want now will stay, and the folks that we want in the future will continue to come.
Thanks, Mark. I think we're getting close to time, and I want to make sure that, Connie, we have time to make space for the student voice. I want to close out and talk a little bit about opportunities for students to really have a call to action and talk to the healthcare system in the room today to say what else can be done to make sure that our students and our future workforce feel supported.
Right. I feel like being in the Oprah Winfrey show going, you take one student, you take one
exactly.
student.
Hey, everybody
I'll
gets
take
a
one
student.
I'll double down on that.
Anyhow, so yeah, so thank you for that, Amanda. So, you know, what we really want is for the health facilities to be in the known and to be mindful of the need that we have in our community colleges to be able to provide these lab experiences for our students. So you were talking about maturity and resiliency, and I think we all learn maturity and resiliency by watching and being part of things that really require for us to act like adults and respond in adults, especially in crisis situations. So it really doesn't help when students are dismissed during the COVID breakout, they were dismissed, COVID pandemic. They were dismissed if there is strikes, they're the first ones to go. And they're dismissed if the accreditation agencies are coming to your hospitals. So they're not able to see the real world experiences of what is happening in your facility, and that will serve them when they become part of your workforce. So please do not have the students to be the first ones to be dismissed, but provide those opportunities for learning. If you have a space in your health facilities where faculty can do the pre-conference, mid-conference, and post-conference to be able to discuss the patient and the visit and the evaluation of students, please make those available. We have health facilities that have open rooms, and when that time comes for faculty to do those conferences, they're not able to have a safe space where they can actually evaluate the student and talk about the patient care that they just provided. And so those are some of the key messages that I want to send. And I welcome you all to be part of this process from the education. I'm really, in awe to hear Dr. Prost, to see how involved she is and the wonderful success she had. We have plenty of opportunities. If you can be part of the advisory board for our programs, I welcome you. That's huge. We want to know what is happening, how our students are performing. We want to be able to improve our curriculum, the experience for our students. We want to make sure they're ready for the workforce. As conversations are happening around AI, please keep us informed, because we need to adjust our curriculum and we need to have curriculum approvals, which takes time and it's a process. So I welcome you to also come to our colleges to see how our students are learning. And our simulation labs, it's incredible the type of simulation dolls we have and all the stuff they can do. And I welcome you to come to our community colleges and get involved. And lastly, we are also trying to increase our men in nursing, and we need mentors for men in nursing. So if you want to participate, we're conducting listening sessions. We would like to have a men in nursing to come for mentors to be able to help men from the pre-application process all the way into graduation. So there's plenty of opportunities to get involved. Please get involved and welcome our students into your facilities.
I want to follow up on that comment you made about advisory boards, because when I hear advisory board, I hear a pretty deep commitment. So I'm just curious about the commitment for advisory boards as a final call to action to this group.
Yes, so the advisory boards, we only have it twice a year. And for nursing, actually, that's one of the things I'm very proud I implemented. I have a regional advisory board for nursing. And last time we had 75 people come, and every single health facility was present, and we were very, very excited. And it's once a year. We're planning the next one in the spring. And so we have also advisory board for surgical tech, or we have advisory board for dental. So it's just a commitment of you coming to a meeting and just kind of guiding us on what is it that we're doing right and what is it that we need to improve. It's just very, very helpful.
I appreciate that. That's a great final thought. So Dr. Provost, Connie, Mark, thank you so much for the conversation today. I'd love to open it up to the audience for these last few minutes to see if anybody has any questions for our panelists.
So before, and I'll make my way over there, let's give them a round of applause. It's been fantastic. So we have about 10 minutes, so plenty of time for questions. And I saw one hand over here.
Thank you all for your presentation. I'm Connie Lafuente. I'm from SDSU at the School of Public Health. We spent a lot of time talking about bringing in the young people, but as we heard earlier, California is aging. And so there are lots of needs for caregivers, but also opportunities for workforce. Could you comment on what you're doing to either retain, bring back people who have left the workforce, or what you're doing to hold to hire older workers? And maybe we could start with the workforce development to say, as you're trying to recruit businesses, is bringing in older workers or tapping into that workforce part of the economic development opportunity here?
Yeah, absolutely. If you want me to start with that, so across the state and in our region, there are public dollars that come down. You know, if in a perfect world, I think we're between leaders right now, but our public workforce system in San Diego is an organization I used to run, and a great deal of my career has been spent in public workforce programs and working with industry from that side. There is a lot of money available for the training of dislocated workers, the uptraining of incumbent workers. There's money that comes out every year to do that. As a state, we need to be probably more progressive than we are in the strategies of looking at folks who are who have left the healthcare industry and may want to come back, or people who have been dislocated from other industries but have some skills that could easily be cross-trained. Again, I would go to places. I think we have the best community college system in the country in California, and the community colleges are a perfect entry point for so many people trying to make those career changes. And yes, I think any strong workforce has to be thinking about where the future workforce comes from by way of the young people who are coming up through a system, but it's only as strong as the workers that they can keep, and the workers who they can continue to sort of become promoted in that industry and begin to mentor the folks who are coming in behind them. So I feel like there's public dollars available for that. I don't know what the state's plans are right now in the budget situation that the state has to be focusing on this, among other things. But I really do think that our universities, our workforce system, and our community colleges could create some great programs where there may not be some, and that there's probably some pretty good ones out there already.
I agree. Dr. Provost, we talked a little bit last night, too, about some opportunities that you have, and you're kind of taking the lead on calling people and saying, hey, come back. So I just was curious about your personal strategy of recruiting those who have left the workforce to come back and work and be a part of the...
Well, one of the benefits of living in a really small town is that there's a lot of relatives. You know, my mom was a nurse, my grandma was a nurse, therefore I'm a nurse.
Yeah.
And so we capitalize on that. We have whole families who work for our organization. Another OG rule, right? You can't work if your mama works here, but we just don't participate in that. So there's a lot of paradigms that we're willing to stretch beyond the usual limits, and we capitalize on all of those opportunities.
That's great, great. I will say too, so I represent the Policy and Innovation Center, which works very closely with the San Diego Foundation, and we're just starting to lean into having a strategy around recruiting and retaining older workers. And there's certainly a space, especially in public behavioral health, where we can really align with their needs, but also be a little bit more flexible with scheduling for peer support specialists, things of that nature on the front lines. And so we just actually had our first conversation yesterday about really looking at how we can engage that specific demographic. So we'd love to talk to you as well about, how we might be able to look at that. Because I agree with Mark, there is public funding, but oftentimes it's not used to its fullest capacity because we're not prioritizing it. So I think that's an area where we really can lean in.
Other questions? See a hand, I'll make my way there.
While he's making his way over there, I'll say the average age of a nurse is 45. And 2 years ago, the average age of a nurse was 45. And 2 years before that, the average age of a nurse was 45. So what does that tell you? We're barely replacing who's leaving. And when all of those 45-year-olds turn 63, now you have a real problem. So I think all of those engagement strategies are important, and retaining them with creative scheduling has been a good strategy for me.
I think in California that academia and the college system and the university systems really need to reanalyze their courses and their curriculums and how they are training nurses. Obviously, being from Britain, we were trained in a very different manner, and it was very effective. And it utilized the college as labor. And I don't mean the American where you didn't pay them. We all got paid 5 days a week, but we worked 5 days a week, and we did, went to class 1 day a week. And you worked at a nurse's aide level, an LVN level, an RN level, and I think we need to re-examine that kind of thing. So you're not worrying about placing students. You're not retraining them when they come out of college to be able to really be effective. But it's going to take academia to change how they see their courses to be able to achieve those types of goals. But I don't need to be hiring nurses' aides when I could have first-year RN students in those kinds of roles and still getting their curriculum 1 day a week. So I think we really need to re-examine how we're training our staff.
That is a very good point and really sage advice. The closest thing we had to the way that they're trained in Great Britain is a diploma nursing program. They were everywhere, and now there are 3 left in our entire country. 3 diploma programs where all of their education is practical experience using their skills. And we don't have those programs anymore because it's somewhere along the way we overvalued the degree. Now, I have 7 of them. I love a college degree, and I'm nosy. I keep teaching because I'm nosy. I want to know what's being taught today. And I think you're right on point that that's one of the OG rules we need to break. We need to go back to having more creative programs.
I would say 2 things too, if I can. I think it's always interesting in any walk of workforce development that when Americans travel to see something that could be done better, it's usually to Europe. The programs in Europe across lots of industries, from a training perspective, are usually ones that we look to, and there's cultural differences and government differences and things of that nature. The one thing, though, the takeaway from that and everything I've seen in countries in Europe across lots of industries is, and I would just say to all of you, it goes to what Connie is urging everyone to do, is how powerful your workplace is as a learning place. So there's only so much that can happen in a classroom. I don't care how good of a teacher you are. My parents were teachers. I respect the profession more than I can put into words. But there's only so much a teacher can do in a classroom. When a young person, when an older worker who's retraining for another industry gets a chance to walk into the setting where that work really happens, that's where learning is at its best. And that's actually where classroom learning becomes stronger, when it's reinforced by what people refer to as work-based learning. So I think anything that allows young people, career changers, to get out and get the work-based learning side of the equation is what makes a stronger workforce, period.
Time for one more question, if there is one. All right. guys are killing me back and forth in the room.
And as you walk in, Demetrius, I just want to add also that at San Diego Mesa College, we have that model for our dental assistant program. Actually, they're providing services, preventive services to the public. So it's wonderful to see the students actually doing that. Yeah.
All right. Thank you for sharing your insight. This is Kevin Kim, medical planner from HKS Architects. And I just want to share what I learned a lot of healthcare conferences so far. So one of the biggest issue in California is nurse shortage. The reason is not about the lack of a nursing school. The ones they graduate the school, they move into medical field of practice because they pay higher. So no one goes to the education part because of lower pay. So that is what I heard, but I'd like to hear from you what is your situation, how you're going to address that issues, and also what can be a solution.
As we heard this morning, we'll need 1 million more nurses by 2030. That number hasn't changed in 10 years either. That data first came out at least 10 years ago. I think that there was one study that was produced on a grand scale. It was a very reliable study that proved that the nursing shortage isn't as bad as we think it is. There are lots of license-holding nurses who are not holding nursing jobs. And so it's not a matter of, as we talked about, the generational shift and the needs, the priorities are different. There's less of a nursing shortage than there is nurses not willing to work in the current conditions. And so we have to create those conditions that make our places that people want to work, doctors want to practice, and patients want to come for care. Developing the workforce and fully engaging in leadership in the workforce is not just because I'm nosy, it's because it's a population health initiative. If I want to take care of the people in Imperial Valley, I have to train people who are members of the citizenry of Imperial Valley to take care of their own friends and neighbors.
And I would add too that in 1992, one of the first programs I worked on was to address the nursing shortage. And every year or decade that has followed, to the very point being made, I don't know that healthcare anywhere in the nation has not functioned in a potential nursing shortage. And so I'm not saying that to say that that's anything that should make people feel good or breathe easier. Somehow, cross all those time frames, cross upturns and downturns in the economy and complete changes in healthcare, you still come forward to today knowing that we still have a nursing shortage. People are still going into the profession, and I think what was just said about trying to, all of us in society, trying to do everything we can to continue to incentivize people to see the opportunities that are in healthcare for them, for careers, not just for jobs, but for careers, is something that crosses outside of this room to other areas of our community where we have to do a better job of sharing that message often.
Well, thank you all for listening today. We appreciate you.